And so, so there has been a downward trend in the United States in incidence of colorectal cancer since 1985. And we know that about half of that downward trend is attributed to risk factor changes, and then about half is attributed to screening. And so we can perform screening with stool-based tests or visual tests. And our stool-based tests, we really have 3 different tests today. So the oldest one is our fecal occult blood test, which is shown here on the left-hand side. And then the newer ones are our fecal immunochemical test and then our stool DNA test. And of course, the pros of these are that they're non-invasive. People can do this at home. But the cons are that they're less likely to detect the polyps, and then the sensitivity is somewhat limited. The guaiac is based on pseudoperoxidase activity of heme in blood, while the FIT test detects human globin. Here you need 3 tests on different days. Here a single sample is adequate. And then our stool DNA test is the most expensive, where we're testing mutations in DNA that are known to occur in colorectal cancer, and really probably works best if you combine it with FIT testing. Then we have our visual tests. One is to do a CT colonography, where you inject some air into the colon and then do a CAT scan. Of course, you can visualize polyps and cancer, but when you see them, you will then have to send them for a colonoscopy to get those taken out. And then our colonoscopy, which is our gold standard, where people can go in either for a sigmoidoscopy that visualizes the rectum and the sigmoid, or a full colonoscopy. Those polyps can be removed. And so if these are normal, people can do them once every 10 years, assuming they're in the average risk category. And so in the United States, our guidelines support starting screening at age 50 for our average risk individual. And you can really choose one of these many tests. So it could either be a colonoscopy or these CTs or these stool-based tests. Now, other countries have been, while they advocate for screening, they recommend certain tests. So in the European Union, they recommend the fecal occult blood test, and to start at age 50. And in Canada, they're recommending the same, either fecal occult blood test or FIT every 2 years instead of annually, or a flexible sigmoidoscopy every 10 years. Now, for prevention, we do know that taking aspirin daily can reduce the risk of colorectal cancer by about 40%, and that's if you take it for at least 10 years. And so here the recommendation is really for someone who is over 50 to take aspirin if they also have an increased risk of cardiovascular disease, so more than 10% in 10 years. And that's sort of killing 2 birds with a stone. And of course, you want to be careful with the aspirin. People who have history of bleeds or a stomach ulcer may not want to be on daily aspirin. So it's a choice that needs to be discussed with the patient's primary care physician. And then we have other protective factors. We know that exercising can reduce one's risk of colorectal cancer, maintaining a healthy weight, alcohol in moderation, staying off smoking, and then staying off our Western diet, our burger, pizza, soda diet, and really aiming for a Mediterranean diet high in fish and chicken and whole grains, fruits and vegetables. And these are the modifiable risk factors then, and their relative risk. And we know that for obesity, for example, if the weight gain happens between early adulthood and midlife, then that's the worst in terms of raising your risk of colorectal cancer. Diabetes does raise the risk, and this is related to hyperinsulinemia. It can act as a growth factor for the colonic mucosa. People want to eat red meat in moderation, but probably the worst is processed meat, which has now been classified as a carcinogen. Now we know that light drinking may provide a tiny bit of protection, but the modern heavy drinkers definitely have an increased risk. And then for smoking, you need at least 30 years of smoking for the association to be seen. Now, secondary prevention is also important for your patients who have already been diagnosed with colorectal cancer. And several things have been shown to be associated with better outcomes after having been diagnosed. Now, we know that if people adhere to the burger, pizza, soda diet, they have worse survival actually after having been diagnosed with stage 3 colon cancer. Same thing for people who take in a lot of carbohydrates or drink a lot of sodas or have a high BMI. While we know that physical activity is associated with better survival, so is having higher vitamin D levels and taking an aspirin. Now, vitamin C and E and beta carotene have been tried, and they had did not reduce adenoma formation. But people who drink more than 4 cups of coffee, they have better survival. And just 2 very, very recent studies showed that higher fiber intake, people do better, and people who eat tree nuts do better than those who eat no tree nuts. And so these are guidelines for cancer survivors from the American Cancer Society. So you want to maintain a healthy weight, you want to adopt a physically active lifestyle, consume a healthy diet, limit your alcohol use, and then I recommend that my patients take a baby aspirin a day if they have no contraindications and vitamin D3 1,000 units a day.